Okay, so it's my pleasure to introduce Dr. Mark Testa from Regenix. He's going to talk today about this whole industry of regenerative medicine, which I think is actually one of the coolest. It's only popped up in the last 10 to 20 years, right? But I think it's one of the coolest ways to avoid invasive surgeries. It takes a little longer, but it's a pretty cool strategy that a lot of people are taking advantage of. And even people on this call have, I'll let them share their testimonies later, have had some amazing experience with it. So Dr. Testa, take it away.
Great, thanks so much, Daryl. Can I do a screen share?
You bet.
Okay, good. Thank you. Here we go. So you're right. Regenix has been around for almost 20 years. Dr. Centeno started it in 2005. Was the first guy in the United States to do bone marrow concentrate, which contains stem cells for osteoarthritis. So in the United States, we were the first, and it's almost 20 years old. They were doing it. Philip Hernegal, an orthopedic surgeon in France, was doing it even before us. So, while it's kind of new on the radar, and I've been in healthcare 33 years, it just takes it takes forever for anything to change in healthcare. So it seems like quick, but it's been a while. Nonetheless, we've been doing this for a long time. We work in the self-funded space, and so we're direct to consumer as well, but let's talk about what we're doing in the self-funded space to try to control costs. We've been doing that in the self-funded space now for about 7 years, and our goal is orthopedic surgery avoidance, elective orthopedic surgery avoidance, not PT avoidance, not steroid use avoidance, not NSAID avoidance, not epidural injection avoidance, surgery avoidance. So we're not stepping over pennies to pick up dollars. Now, I talk to hundreds of advisors a year, dozens of employers, and Business Group on Health last year said this, MSK was the number 2 cost for most employers, cancer being number 1 now. And yet, really, I don't see that many doing a lot with it. Some have digital PT, some have surgical centers of excellence, some have reference-based pricing. Interestingly, I saw a slide from Payer Compass last night at our little event. 94% of doctors and hospitals in Colorado take reference-based pricing. So that is, a solution. But are all surgeries necessary? That's another question we need to ask. So in most health plans, MSK is about 15 to 20% of that. Half of that is elective orthopedic surgeries. But I also think this is important. I just wrote a paper about this. This should be coming out shortly in EBN or Benefit Pro or somewhere. MSK touches the entire body, and it touches the entire health plan. And what I mean by that is when we can't move, and I'm not talking about triathlons and marathons, but just healthy activity, blood pressure gets worse. So cardiovascular disease, the leading killer of Americans, gets worse. Metabolic health gets worse. We definitely know that when we can't move. And I still see patients 2 half days a week. So this is what they tell me also. Mental health, 33% increase in anxiety and depression with musculoskeletal pain. Sleep is affected. Anyone that, whoever's wife had surgery here, I bet she's not sleeping awesome. I know surgery's a bigger deal, but just general knee osteoarthritis or back pain affects sleep, which, if you haven't read Matthew Walker's book, Why We Sleep, it's an important thing to sleep. That's a great read, and it really talks about the importance of sleep. But weight goes up also, and with, which we don't need any help with 60% of Americans overweight and obese, because with that are 12 cancer diagnoses. So it's not just the biology, but the whole health plan is being affected. And I'd love to get data on that, and I'm working on it with some people to see how does an osteoarthritis, how does a lumbar disc touch all this. So I want to see it in numbers, but we know clinically and we know in the research that it does. Now, what is Regenix? We are interventional orthopedics. We're going from the knife to the needle. We're less invasive. We're using the patient's cells, their cells. So when we talk about stem cells, and I just had a call with an advisor today, he said, hey, this group's very Catholic. They're going to ask questions. I was like, these are your cells. So they don't have to worry about them being embryonic or anybody else's or any of that. They're yours. They come from you. Bone marrow concentrate comes out of the iliac crest. Blood platelets, platelet-rich plasma comes out of the blood, out of the arm. And then we use needles to put those in using video X-ray, fluoroscopy, or ultrasound. And we can target the tissues where they need to go: ligaments, cartilage, tendon, bones, joints, what have you. So immediately less risk with all of that. We have a national physician network. We're the world leaders in research on this. We've published 43 peer-reviewed papers. We've got 3 randomized controlled trials in there. We got 3 quality studies, quality of life years adjusted, looking at knee OA, spine surgery, and rotator cuff. One of those will be published this year. And when you look at the cost, the economic cost value, what we're doing is better than, surgery for knee osteoarthritis. And then we have a national network, and really the only self-funded employer practice doing this. Again, we fit in after these things on the left: PT, chiro, steroids, NSAIDs, injections, stop working, and before people need surgery. And we can reduce the need for up to 70% of elective orthopedic surgeries. Employees who make their living and live paycheck to paycheck really find this very valuable, because they don't want to miss work. They can't afford to miss work. And so they love this because they can get back to work in days, not weeks or months. And there's no PEPM cost to add this. We make our money. We retain a portion of the physician's charges, and that's how we make our money. So it doesn't cost an employer to add this to the plan. And I'll get into more about how we're making sure we have appropriate patient utilization here in just a minute. So we can reduce the need for unnecessary surgeries here. We treat everything literally from head to toe, but the 3 most common things, and that's just not us, but that go to an orthopedic surgeon. Number 1, knees. Knee replacements, we're almost up to 1 million a year. And that's going to continue to grow, largely because of weight and obesity wearing out the knees. And so we're going to see more and more knee replacements. Knee meniscus, randomized control trials now are showing that these, for people on this call that are my age and around my age, are no better than fake surgery or PT. And yet we do 1 million knee meniscus cleanups a year. So Aetna's not paying for those anymore, knee debridements. So they caught on finally to the research that this is a waste of their money. Number 2 thing we treat are spine. Right? A lot of people get spine surgeries. Edison Healthcare says 50% of spine diagnosis is incorrect. Of all the surgery failures I ever took care of in practice, and I worked in physiatry, pain management, orthopedic and spine surgeons' offices, they were spine surgeries. We had 4 opioid deaths in 1 quarter in our practice because spine surgeries didn't work. And these were not people abusing opioids, but they were just taking them as directed, and they went haywire. And this was, I often say, during the opioid epidemic, which is still going on, but this was like 2007, 8, 9, 10, when that Purdue rep was in our office every week bringing us lunch. And if I ever see her, I'm going to ask her, did you know? Because I want to know if you watch Dope Sick. And then the number 3 thing that we treat, shoulder, rotator cuff labrums. I just saw a patient Tuesday. I asked him, how long are you going to be out of work? 6 weeks. 6 weeks. You get a rotator cuff with us, you can go back to work in a couple days. We've published papers on the rotator cuff tear repairing itself. We published a randomized control trial last year, ACL tears, certain tears, repairing themselves using bone marrow concentrate stem cells. This year, we added 160,000 new covered lives, 1-1. We're over 1,300 self-funded clients. And it's important to know this because we're going to get into it in a second. We're considered investigational by the BUCAs, by the fully insured. But that's not stopping huge fire department trusts, publicly traded energy companies, school districts, municipalities, TV broadcasting stations. These people, they bring their lawyers in. This is fine. When you amend the plan document, stop loss mirrors that amendment, and we retain 99% of the clients that we start out with. We already work with like 80 TPAs, including some bigger ones, right? We work with the BUCA ASOs. They make it difficult, but we work with them and they do what we need. Meritain, we're on their website as a solution. UMR, right? You would think they'd be difficult. They're really easy to work with. So we work with a lot of them. The stop loss, like I said, mirrors that. And you can see, you know, all the big stop loss providers have no problem with us. And now let's talk about this investigational thing. The book is considered investigational. And we're going to touch on all those reasons. But one of the big reasons you don't see it in fully funded plans, fully insured plans yet, is there's no way to standardize the concentration of what people are being injected with. There's not a really good standardization yet. And so you think about a medication, right? Meds are standardized on dose and frequency. There's no real standardization yet. We are standardized, but in general, but we're going to see this come. We're going to see this in the next 5 years, and I'm going to show you who else is already doing this. But we published the largest safety paper in the world on bone marrow concentrate for stem cells, 2,372 patients, 3,000 procedures, 4 adverse events. This is the 3rd paper of its kind. This is very safe. These cells are yours. They come out of you. They're concentrated. They go back into you for a couple hours. You compare that to a knee replacement, 6% adverse events at $1 million a year. That's 60,000 patients. And I treated patients with this. Metal allergies, strokes, heart attacks after these joint replacements. These things happen. They're real. And like I would tell my patients, hey, no one thinks it's going to happen to them, but it happens to somebody. That's why we have data on it. We've published, like I said, 43 peer-reviewed papers. That's all on our website for people to see. We put this infographic together on bone marrow concentrate. We stopped doing this in 2019. But this is, if you want this, you can click on all of these. They go straight to PubMed. These yellow ones are ours. We've added another dozen. So there is a lot of research on this. This is not unresearched. When we look at PRP, platelet-rich plasma, which you hear a lot of athletes getting done, and maybe some people on this call have had it done. Just for knee osteoarthritis, this infographic had 24 randomized control trials that showed that it worked better than conservative care for knee osteoarthritis. And so much so that last year, American Academy of Orthopedic Surgeons said, yes, we're going to endorse this for conservative care for knee osteoarthritis, because it does work better than what we're doing, PT, steroids, and non-steroidals. So that I thought was a big step on their part. TRICARE added PRP in 2019 for knee osteoarthritis and tennis elbow. So we're seeing this starting to inch its way in, but equally as important, and I heard this at a physician conference last year, Mayo Clinic researcher, and if people on this call know Mary O'Connor, those two published a bone marrow concentrate paper on knee OA using stem cells. And I talked to Mary about this, and her partner, Dr. Shapiro, said this on stage. 68% of academic medical centers around the country are doing PRP. Here at CU, Emory, Stanford. Who else is doing this? Mayo Clinic, Cleveland Clinic, Hospital for Special Surgery. In fact, Greg Lutz at HSS just published a book. It's a great book. Heal Your Disc, Heal Your Back Pain, injecting platelets into the disc. He's published like 3 or 4 RCTs on this, and it is making real headway. So this stuff is coming. And I told a patient yesterday, this is the best time to be alive in orthopedics. FDA, what does FDA say about this? This falls under the physician's practice to license medicine. 21 CFR 1271, the regulations are very clear. It's not gray, it's not ambiguous, it's not confusing. They say it's a tissue, and it falls under the practice of medicine. It is not a drug. It becomes a drug when they're someone else's cells, when they're significantly manipulated, where you're adding chemicals to them, and when they're what are considered non-homologous. For example, using fat. Fat doesn't turn into anything in the body that's related to the musculoskeletal system. So bone marrow concentrate, though, falls under the physician's license to practice medicine. And to put this into context, you know what else doesn't fall under FDA? Orthopedic surgery, meniscus surgeries, spine surgeries, rotator cuff repairs. None of that falls under FDA. The things going into the body might, the device, the mesh, the hardware, but the surgery in and of itself, if it's just a stitch up and a cleanup or whatever, does not fall under FDA. We have a national network of physicians right here. Those red dots are new ones coming on board this year, this quarter. I mean, some of them are already on board. But we have about 90 clinics. We vet these docs. They're all MSK specialists. They have to prove to us how many procedures they have done in their past using ultrasound and fluoro, and in what joints. They take a 25-hour test once we accept them into the network. They get drug checked, background checked, and all of that before they even get listed on our website. And then they come to Colorado for additional training. So we do as good a job as we possibly can with recruiting the right physicians. I was the physician recruiter 13 years ago. You'd think we have more than 90 clinics. We want quality, not just quantity. And we turn away a lot of people who just don't have the skill sets. Now, I mentioned that physician experts, we got a lab in each doctor's office where they can concentrate these cells. And again, we got registry data, so we know what we're going for. We can concentrate cells based on age, body part, knee, hip, shoulder, spine, based on the kind of tissue it's going into, ligament, cartilage, bone, or tendon, and based on the severity, mild, moderate, and severe. That's why we get reproducible outcomes. And then we track everyone's data, right? Their patients give us in the registry, it's patient reported, from time 0 at 1 month, 3 months, 6 months, and annually, their outcomes by pain, function, and overall improvement. And that's all on the website, totally transparent for everyone to see. We also track their net promoter scores. Last year, we had a Validation Institute report put together. This was not cherry picked, but it was a large group, 77,000 lives in all 50 states. The interesting thing about this is there were 126 cases. They paid us $923,000. We compare that. What I said was earlier was the surgeries avoided, and I'll tell you how we make sure of that in a second, to healthcare blue book costs, because that's about the only way we can get the all-in costs. It's hard to get the facility, the anesthesia, the piece, the metal piece, and the professional fee. So we use healthcare blue book, fair market value. Those costs avoided were $2.6 million. Now, we know everything in medicine doesn't work 100%. We know that about ours too. So we baked in failure costs for our procedures at $446,000. And so when you add those two together, 446 plus the 925, it's 1.3 million minus the subtracted from the 2.6. This group saved 49%, all in costs to us and failures. So totally transparent. And so we see this consistently with our entire book of business. This is not just let's get the best case scenario. And the only clients we've lost in 7 years go back to fully insured or through an M&A move in some other direction. Again, we track our failures in our registry. They're very low. They're less than surgery failures. If anyone fails one of our procedures, rarely does it happen in the same plan year as they had the procedure. Now, we have a medical utilization management program we put in place in 2019. When the patient goes to see the physician has to check the boxes. This patient did all of the conservative care already. Their next step would be surgery. If you hurt your back shoveling snow in Wisconsin on Saturday, and you come and see me on Monday, we're going to say, hey, did you do PT? No? Okay, well, that's where we're starting you then, in PT, not with a Regenerative procedure. So the physician won't get their treatment approved until those boxes have been checked. Those are auto-adjudicated. It does not slow down treatment, and it doesn't increase cost, because a lot of times, about half those people, they don't ever need us again after that. So our goal is surgery avoidance. Or if they've already seen an orthopedic surgeon and they know that's their next step, that gets auto-adjudicated as well. And we make sure that's done. So to add Regenerative, we've done it 1,300 times. We've got this implementation utilization guide. We share it with the producer. We share it with the TPA. We share it with the employer. It's got everything in it. Our contract, our fee schedule, you pay the same in Beverly Hills as you do in New York City, as you do in Tulsa, Oklahoma. It's got our sample SPD amendment. It's a 1-sentence amendment. It's a 2-sentence amendment if you want to put plan design in there. So that's very simple. Where are we? We do this. This is no cost either. Utilization strategies. We will co-brand a benefit card, and we pay for all this with the employer's logo on it. We mail it out to employees. We want you to know about this. We work with HR to provide them a web portal, regenxbenefits.com/your company name, and HR can send everyone there to chat with our call center to learn more about their benefits, to sign up for a webinar, which brings me to number 2, educational webinars. I do 2 a week. We send out an email to HR. They send it out to their team. if it's appropriate for them. And then they come to webinars and they learn about it. What is Regenix? Who does it help? How does it help me? All of these different things, all for free. And then with the independent TPAs, not so much with the BUCA ASOs, but with the independents, we get file feeds every week, targeted outreach. We will call, email, and send a postcard to let you know you have this non-surgical orthopedic benefit. Go to the web portal to learn about it. So we do everything we can to get in front of that. And look, as a clinician, it's telegraphed. You had PT, you had a steroid shot, you had Synvisc, we know what's next. I train quantum pods. I train direct primary care. We have some cases with Nextera. Dr. Flanagan's team knows our protocol, and so they make sure everyone gets conservative care before they refer them to us. We have a large employer with them. We're doing the same with Peak Med. I've trained on-site clinics and then connected them with the local Regenix physician so they have a relationship as well and they can work together. And back to what I started out with, if this affects human beings, full night's sleep, back to my workout routine, improve physical and mental well-being, it really does. Here's my ask all the time. I'll run a cost savings analysis for you. If I can get the CPT code, procedures that were performed, and the costs paid, which is rare, we'll use Healthcare Blue Book. I can run a savings analysis that has our average cost baked into it, which is $7,300. And it has our failure rate baked into it. And I'll be able to let you know how we can help you save money. And so you can go back to the employer with all the information necessary. And if you need a heat map, like we provided this employer, this is a assisted living group with clinics up and down the Eastern Seaboard or housing. And we showed them where they could find a Regenix clinic, the farthest one, 115 miles away. So we make it very easy and very affordable for people to access what we do and help people avoid surgery. So that's a lot. Thank you very much. Love to take some questions.
Dr. Testa, address the real simple question of what is regenerative medicine doing? And talk just a little bit about the fact that, what you're trying to do, rather than fix a tear with surgery, what is it that these stem cells are doing? And how long does it take? Because it is a longer process, no question.
So not necessarily a longer process. So we'd rather regenerate than replace or repair, right? So we'd rather regenerate. So in a rotator cuff tear, and I don't want to, this is not all of those. It can regrow that tendon. It can regrow in ACLs, not all of them, the ACL. You're not going to see a new meniscus come out of nowhere. You're not going to see a disc get plump again. But let's use the spine, for example. When we put it in the epidural space, it's not just the nerve that's getting squashed, but with the nerve travels a vein, an artery, and a lymphatic. And when those get all squashed, the blood to the nerve dies off as well. When we put platelets in there, there's certain things within those platelets that get those blood vessels to grow back, getting the nerve to respond and work properly, and calming things down. When we go into the spine, we tighten up the ligaments around the spinal motor units. Those are the segment above and below the problems to stabilize all of that. So we tighten up the ligaments. And then we get into the joints. And so we're not turning those joints into 20-year-old joints. We're taking them from a catabolic breakdown process to more of an anabolic repair process, because every tissue has repair cells in it. And so we're giving those cells more energy to work harder, longer, using platelets, believe it or not, transferring the mitochondria from stem cells into those cells. And we're giving the body the energy it has to do what it can naturally do, given the chance. Now, people ask, well, if it's already in the body, why isn't it doing that? Because we got enough blood vessels to go around the globe. So these cells are literally all over the place. They're not 100% where they need to be. When it comes to repair, or when it comes to time, again, you'll see this on our website, 47% pain reduction in 1 month with our knees. And I like that cohort because there were 16,000 patients in it. But people get functional quickly, pain drops really quickly, and the recovery is a lot less than surgery. So the time to get an injection is 1 day for PRP. We have a 3-step stem cell process. It's a Monday, Wednesday, Friday. So it's a 3-day process.
And is it necessary to, like, a 2 months later come in and do the same thing? Or is it kind of a one-time go in for those 3 days and you're done?
We do one and done. That's our goal, one and done. And we have a protocol too. Like if you're not 50% or better, we would wait 6 months to even assess that. If you're not 50% or better, then that's not the treatment for you. You might need to go have surgery, but we usually give it 6 months before we make any real determinations on whether it's a failure or not.
Martin is asking, do you have any interest in offering care to state Medicaid plans and Medicare Advantage plans?
I mean, a couple things. The short answer, yeah, of course. And I've talked to some people in Tennessee about this. The problem, we have 90 clinics, number one. And I don't know if we could serve all of that, truthfully. Ideally, I think it would be a great cost savings. I mean, we got Denver Health Medical Plan here that I've been trying to talk to for years, and you know, they're at risk and they don't even pay much attention to me. They haven't even responded to anything. So the short answer is yes, if we could make an impact and if they could get past the investigational.
Enzo's asking, is there any age limitation to your process for arthritis relief?
Specifically in men over 55 with hip osteoarthritis. Again, because of our registry data, we know that won't be helpful at all. And so if you called us and said, hey, I got hip OA, I'm trying to avoid a hip replacement, we'd ask your age and say no. Certain types of ACL tears unrelated to age, certain types of rotator cuff tears and damage in the rotator cuff or in the shoulder, glenohumeral joint. We can get bones to regrow, or with avascular necrosis where there's bone death. But there's 4 stages of that. So there's a couple stages. We can affect the first 2 when they're more mild damage. But the real only age, hard and fast, is hip OA in men.
Okay. Anybody else have any questions or anything they want to add?
Why? And it's interesting that it's hips in men. It's not women. If you're an 85-year-old woman, you can do this with a hip.
I don't know about 85 because I've never actually done it, but we know in men specifically, and we know this from the research on the environment of the hip. It's just a different environment versus the knee. And it doesn't have sort of the regenerative capacity in it. I don't know about an 85-year-old woman being, I don't know how many of those we actually treat. Our area under the bell curve is probably maxes out at about 70.
Other questions? I mean, clearly, Bill's jumped off the call, but with his wife who smashed her ankle because she fell, she's going to have surgery to rebuild multiple broken bones. Saying, I fell off a ladder 3 months ago. I had to have surgery to bring my bones back together with some pins. There's obviously going to be some accidental things but anything that's just age related or arthritis related or a deterioration, degeneration of things, that's the kind of thing that the regenerative medicine applies to, right?
Yeah, exactly. So yeah, non-traumatic, non-trauma related pelvis fractures that are shattered like that. Those need surgery. But yeah, osteoarthritis, wear and tear, degenerative changes, spinal degeneration, things like that is exactly where we fit in. Great.
Well, thank you, Dr. Testa. I appreciate it. I do, as we're just wrapping things up with a couple minutes, wanted to mention that I've watched a couple of films that I would recommend. One's called Diagnosing Healthcare, and the other one's called The Healthcare Divide. If you get a chance to check those out, both were pretty enlightening. Our next meeting, which will be on April 14th, Walmart Health is going to be presenting a lot of their solutions they've come up with. They're definitely working hard to drive patient-centered healthcare with both their virtual as well as they're doing some pretty cool things with some clinics. They just announced opening up 75 clinics at their Walmart location. So they're going to talk about that. So hopefully you'll join us again. Anybody have any last minute questions or comments? Cynthia.
Daryl, when is the session with Walmart Health? That should be really interesting as well. And thank you very much, Dr. Mark, for your presentation. I spent 30 years of my life in stem cell transplantation.
Oh, yeah?
Yeah, having founded ViaCord and pioneered cord blood stem cell banking many, many years ago, eons. But
So,
it's
so
exciting to see success.
we have these meetings the second and fourth Friday of every month. So the 14th of April will be our next meeting at 2 o'clock Mountain Time. So that would be 4 o'clock your time.
Thank you.
All right. Everybody have a great weekend and thanks for joining us.
Thanks for allowing us to be on the
Thank you.
call. Thank you, Don.
Thank you.
Thank you,
Daryl.
Daryl.